Good? Yeah. And then I think how we looking? How we doing?
Good, good. See here? Oh, it's a color. I didn't put that there.
I know you didn't. So how do we look? How do we sound?
You guys look good. You guys sound great.
Okay, great.
All right.
Excellent.
Look good, sound good, feel good.
So this is, I think this is, Gene, can you shut the door? This is probably outside of when my dad was on with Iad.
Mm-hmm.
This is like
No, he was on by himself.
oh
You and your dad.
yeah, I'm saying and yeah.
Oh, and yeah.
This is the guest that I'm most proud. I admire the most. I look up the most to the most. So beyond like, I actually hesitate to call him a colleague. He's much more of a mentor, a hero. And I'll say a few more words about that before we get into the conversation. But Dr. Michael Lamacchia, who's sitting to my right, is a real hero and an incredible figure in pediatrics, not just nationally, but especially from my home state of New Jersey. I'll ask Mike to kind of give his story, but I do want to make a couple of very personal remarks. I think the best pediatrician I've ever worked with was my dad. He was the consummate pediatrician. And the pediatrician he admired the most, and one of the few he would call for professional or clinical advice was always Mike. And I'm lucky, me and my brother is lucky that we inherited that friendship. And so take that for what it's worth. I'm friendly with, I have good relationships with many of the chair people these are the best children's hospitals in the world that were within 30 miles of here. Columbia, NYU, Sinai.
Can you just pull your mic closer?
Yeah, there's no one I respect more than Dr. Lamacchia. And besides what I've mentioned thus far, I've had the honor of working side by side with probably over 10 different doctors that he was responsible for training through his program at St. Joe's. Whether it was Dr. Nam, Dr. Valdivieso, many others who were trained. They're excellent doctors. And then they joined us. And I'm grateful for all the teaching that Mike and his team put into those folks. And then the excellent care that translated into the kids that we took care of in northern New Jersey. And we knew that if they came out of Mike's program, we didn't have to question their clinical acumen or their ethics. And so we'd say, hey, Mike, we got a inbound from one of your residents. What do you think? Oh, she's great or he's great. Boom. That's it. It's the only time we wouldn't even interview someone if Mike vouched for someone. And I think St. Joe's must know how special of a leader they have in him, because I was just telling him today or yesterday, I looked up all the guys and gals who run children's hospitals that we are affiliated with and so on and so forth. And none of them have the tenure that Michael does. And so I don't know where that stacks up, but it's pretty incredible. And he could talk a little bit about his journey. And the last thing I wanted to say about Mike, and then maybe we'll do housekeeping, that Mike could talk about his background, and then we could get into the questions, is he is in charge of the children's hospital that serves a community that actually my friends here sitting with me are from, in Patterson, right? I don't know if you know, Kavir lives in Patterson. Mo's from that area, right?
Born and raised in Patterson.
Born and raised. And so, so it's an incredible community. And it's one that we're very proud to have served and continue to serve and to have roots in. And so this is a very, very special guest. I'm humbled that Mike took the time. Very, very busy guy. But in terms of knowledge around all things pediatrics, academics, medical education, clinical, the business of medicine, where medicine's going, where it's been, what's right, what's wrong, very humble, very smart. There is nobody better. And so I'm really looking forward to tonight's conversation. Some housekeeping. This is Christmas weekend. So we have a couple of yoga classes in the studio in Paramus. We don't have any yoga classes outside of Paramus this weekend, and no prenatal classes because it's the holiday weekend, right? But other than that, we wish everybody a very Merry Christmas. We wish everybody very, very happy and healthy holidays with your loved ones. So take the time to enjoy it. And we will be back next Thursday. And with that, I would like for Dr. Lamacchia to maybe talk a little bit about his journey. And then I'm sure we're going to have a bunch of questions.
Well, firstly, I'm so excited to be here today, and I'm very proud of you, and I'm honored to be here. Your dad was my mentor. When I first came to New Jersey, I came to New Jersey from fellowship. I did my fellowship at UCLA, and I had an NIH training grant to take care of kids with HIV. So I came to Patterson, I came to St. Joseph's to give back from that grant that trained me. And it was supposed to be for 2 years. But now it's been 28 years, and I wouldn't be any other place. When I first got to St. Joe's in Patterson, my parents lived in Italy, and I called them and I said, this is going to be the last place I ever work at. And so far, that's been the case. So when I came to Patterson to take care of kids with HIV, there was really only one drug for HIV. It was AZT. And so we were able to do clinical trials with drugs that some of the adults were able to take, and able to do some protocols to prevent the transmission of HIV, which was to give AZT to mothers during pregnancy, at labor, and the babies for the first 6 weeks of life. So that became the gold standard. And I'm so happy to say that in 18 years, we haven't had a baby born with HIV.
Wow.
The original research was a 75% reduction. And, we've been extremely fortunate that we haven't had any babies born with HIV. So that's what my journey has been. And I've been the chair at St. Joseph's for now almost 20 years. And I practice infectious diseases, and I practice hospital medicine. And I'm so delighted to have the Baker family, very dear friends. Your dad was my mentor early on, and believed in me. And we've had a great relationship, and that relationship has now gone to the relationship that I have with you and your brothers. And I am totally so excited to be here with you.
Thanks for coming, Mike. And I hope the people asking the questions tonight know how lucky we are, and kind of the brain power sitting to my right on all things pediatric infectious disease healthcare. So let it rip.
First one, this was asked a couple of times, is if there's any new information regarding autism.
So I'll say a remark, and then if Mike wants to just opine. Before we sat down here, we, even though Dr. Lamacchia is an infectious disease specialist and I'm a general pediatrician, the conversation immediately went to this topic. And that tells you something, right? I'm not a developmental pediatrician, nor is Michael, but from where he sits and where I sit, that's really probably, and without getting into a debate, that's really the biggest issue that we face. Is there's this just perpetual rise in developmental issues in kids for whatever reason, right? And it's probably a mix of reasons, but it is what it is. More than ever before, we have these issues, developmental issues in kids. And unfortunately, and then I'll pass it to Mike, we actually have dwindling resources. So in the face of rising developmental issues, I tried, but I didn't want to, okay. Yeah. In the face of rising developmental issues, unfortunately, we're seeing dwindling resources to help these kids and their families. And Mike can talk about how many retired and so on. And even if you want to talk about some of the creative solutions he has to solve for this. But on a clinical basis, in terms of treatment, and again, I welcome Mike's input on the clinical basis as well. The unfortunate thing if we want to talk, turkey about this, is what we're able to do about treating kids with autism is not as advanced as we would like to think. It's not as different as it should be from 10 years ago. There are some tools that are important, ranging from ABA, other therapies, speech, OT. There's a million things that we do, but they're not very different than what we did 10 years ago. And it's one of those things when I'm in a room, like if I look at like certain pneumonia or meningitis infections that we used to treat 20 years ago, we're way better at it, like mortality rates, morbidity rates. I mean, Mike just gave the example about HIV. I remember, I remember vividly when HIV, when I was a teenager, was like almost a death sentence. And the fact that now that statistic you said about how we've decreased it is a remarkable victory for medicine. We haven't had that progress in autism, right? And that's the developmental disorders in kids is really kind of the epidemic we're facing of our generation now. And so I actually will tell you, at Baker Health, we're great at leveraging relationships. We're great at finding the best doctors for our kids. I think we're the best at getting whatever services we need for our kids, but we're still desperate, as you can imagine, when it comes to, okay, the kid is, 3.5 years old, severely autistic. It's like, okay, do some speech therapy, ABA, and there's a lot of alternative fringe things. I'm very open-minded because my approach, Mike, if I can't tell you what to do to fix the situation, then I'm open to hear what people have, because all I know is I don't have the answer. So I can't say those are the wrong answers. And I'm willing to open my mind and learn and functional and holistic, because I know what we're doing now is not enough. And then even the limited things we do know, we can't even get access to them because there's a shortage of those resources nationally. And so it's not great news on that front, but with that, as I said, Mike and I were talking about this earlier, so I'd love for him to kind of share what he can.
Yeah, over the years, the statistics have gone from, I remember them nationally, 1 in 120, and still higher in New Jersey, to 1 in 90, and now in New Jersey it's 1 in 60. Mm-hmm. So there's been a rise in the number of cases of autism. I think New Jersey may have a higher rate because there are a lot more folks that can diagnose it. Yeah. So I don't know necessarily that there's something in New Jersey that's particularly enabling autism to occur. And you're right, there's not a whole lot of things that we do differently than even 10 years ago. I think early diagnosis is key. Starting therapy is key, whether it be ABA therapy or DIR, all the other modalities that help speech, language, OTPT, all of the things that are needed. I think over the years we've seen that there are some genetic disorders that are the cause of autism, roughly around 10%. So diagnosing those and caring for them, I think is important. What has also happened simultaneously is that the number of developmental pediatricians has actually decreased. There was an aging pool of developmentalists that have, over a short period of time, retired, and there haven't been enough developmentalists that have trained to be able to take their place. And so there are long wait times, unfortunately, to see a developmentalist. So one of the things that we've are starting to develop, because there are a paucity of developmentalists, is to have very good general pediatricians that are trained in some aspects of developmental medicine and that follow protocols and that can bounce ideas off of developmentalists that are available, like the tougher things, and this especially in the areas of ADHD and autism. And we're calling that individual an expert generalist. And so this is how we hope to sort of continue to meet the growing needs.
Yeah. And I think that last part, the necessity is the mother of innovation, And I think what I'm hoping, I think I mentioned to you, I've met with colleagues who are developmental experts in the past few years about coming up with some creative solution, leveraging technology, looking at the clinical protocols, dissecting them, kind of flipping them upside down and saying, how can we do more with less, right? We have X amount of developmental specialists. We have X amount of advanced practice clinicians who have experience with this, X amount of nurse navigators. What are the surveys parents and teachers fill out? Is there an AI solution here? Like algorithms? How can we kind of do more with less? And it's not been easy. And it sounds like you guys are starting to kind of make hay here. And, as I told you, I would love to be at the front of the line to kind of pilot it or work with you guys for our members. This is an area of great need. So I think we could go on to the next question, but that was a great question.
Somebody wanted to know if you think in the future there will be an in-house ABA specialist to help provide services such as some places offer speech services.
Within Baker Health.
Anywhere, but maybe within Baker Health.
In-house ABA services.
ABA services.
I mean, to be totally honest, my experience has been that once we get the diagnosis, the ABA companies are pretty fast, efficient, quick get there. That to me at least, that hasn't been the friction point in the workflow. Everything else has been, but that hasn't been it. But yeah, I think that's probably something that's going to happen. I think right now the energy is being spent where the friction lies.
Good question here from one of our members. They asked, can you provide insight into the importance of HPV vaccine for my adolescent, and what are the potential long-term effects of HPV in children / young adults?
So Mike, that's up your alley.
Yeah. I think it's very important, and to get the vaccine earlier on. There's a range to get the vaccine, but the earlier, the better. What it prevents is cancer. So getting the HPV vaccine can prevent the majority of the types of cervical cancer. And it's important to do so prior to sexual activity, because that's how the virus is spread and is introduced. So the earlier the better. It's not a vaccine that promotes sex. It's a vaccine that prevents cancer. And that's a really important type of cancer to prevent that, kills many women.
And then also, can you touch on it? Not a question, but just what I was wanting to ask. The HPV vaccine for males, because it seems like, males don't need to get it, and it's only like a female kind of vaccine.
No, also males.
And like the importance of it as well.
Yeah, because that's the font of disease, right? Potential for disease.
Next question. We had a couple similar questions to this. Question is, are there any specific signs or tests to identify if my children may have an immunodeficiency or disorder, and how does this impact their susceptibility to various infectious diseases?
So, basically, the things that give us a clue to potential immune deficiencies are either recurrent infections, so many infections, let's say, for example, otitis media, if there's, over 6 in a 6-month period or 8 in a 12-month period, that can give us sometimes an indication that there may be an immune deficiency. If there are recurrent infections in the lungs and the sinuses that happen on a frequent basis in kids, or recurrent large-scale infections like meningitis or bacterial infections or severe skin infections. Those are things that make us think of the possibility of an immune deficiency. And based upon the type of immune deficiency are therapies.
One thing I'd like to add to what Dr. Lamacchia said, when you come out of an academic, or Mike resides in an academic environment, when you come out of an academic environment, what you see, and I'd be interested how you think about this, Mike. What you see is you come out thinking of these terms like immunodeficiency in a very academic context, meaning you come out and when you're in private practice, let's say, you're like, okay, did this patient have, X amount of recurrent rhinosinusitis, antibiotic courses, and so on? Maybe it's a missed cystic fibrosis. Maybe it's a missed IgA deficiency. And you go through kind of the academic exercises, which are appropriate. A funny thing happens when you see a lot of, now hear me out on this, when you see a lot of non-complicated normal cases in private practice, you start to change in your mind what the definition of something like immunodeficiency is. And what I mean by that is this: when you're at an academic center, and when I was, you're getting like tertiary, quaternary, complicated cases. Like you're getting the sickest of the sick. So you actually see a lot of the rare stuff. You see a lot of cystic fibrosis, sickle cell. You see a lot of things. So then you're dealing with what I'll call the quote real immune deficiencies. But what I've learned is most immune deficiencies are not an official diagnosis, but they're due to obesity, poor diet, lack of exercise. And so most of the families that come into my office whose kids get sick more often than not, or with the adults especially getting sick more often than not, when you talk to our adult doctors, you can easily categorize them as having an immune deficiency. It's an unofficial immune deficiency. It's not the kind they have in the textbooks, but if there's poor diet, if there's lack of sunlight and vitamin D, if there's lack of exercise, we know all those things boost your immune system. Well, you might not have cystic fibrosis. You might not have IgA deficiency. You might not have an official diagnosis, but I would submit that the most common immunodeficiencies we see are due to things we can control, even though the parents go to the genetics, or they go to let's do a fancy blood test and see why Jimmy keeps getting sick. And it's actually the basics. And so I find that most of the amplified rate of disease we see is due to, like, look at what happened with COVID, right? Like, what besides age, the next risk factor is obesity, right? And we see that with a lot of diseases, and poor diet and exercise and sunlight and even stress, just poor mental health. We know study after study has shown us leads to increased immune susceptibility. And so I would urge anybody who's listening, don't go chasing the zebras, as we say. Focus on the horses in this case. And I think doing the right thing in terms of diet and exercise and sunlight and mental health will do a lot more for your immune system than fishing for that 1 in 1,000 possibility.
Yeah, I think you're right. I think my perspective is actually, skewed because of the tertiary nature of what I do. And, I think you have to evaluate, for otitis media, for example, one of the predisposing factors to get an otitis media is to have a viral infection, a respiratory viral infection. So if you're in an environment like school or daycare where you're exposed to a lot of different viruses and get it on a recurring basis, and because of that, you get an otitis media, I think that has to be all taken into consideration. So you're absolutely right.
Nice. Next question for Dr. Lamacchia. They wanted to know if pandas is a real thing.
I think it is.
Should we define it? Because other than the person who's asking, right, he might not know.
So it's a post disease from streptococcus that then produces symptoms like tics and obsessive compulsive type behaviors. I think it's a real entity. I practiced for a little bit of time in Brooklyn, and where there was a high incidence of actually group A strep infections. And we had a large cohort of kids that also had these behavioral sequelae. So I do believe it.
Next question. Someone getting back to like the development part of kids. They wanted to know, why are developmental delays on the rise?
I'll let you answer that very hard question.
Well, To be honest, I don't know that they're necessarily on the rise. I think the recognition is on the rise. I think the awareness is greater. And I think, behaviors that may have, been thought of as, oh, he's just a boy, or things like that, or categorized differently. And there's more of an awareness to find those things. What do you think?
I don't know. I haven't been practicing long enough. That's why, I don't know. I asked my dad, he gave me a wishy-washy answer because he practiced kind of across the spectrum. He didn't give me a great answer. Because I've been practicing for 15 years. So it's hard to say, the only thing I know is when I was in training and when I came out, 99% of what we were taught and we saw was infections and autoimmune and genetic, now all I deal with is developmental issues. And I think there's no question the large part of it is awareness and diagnosis and sophistication on a diagnostic level. But I don't know. We have a lot of families who have 2 kids and they're both autistic. Was that happening 25 years ago? I don't know. We know there's this, 4.5, 5 to 1 over-index male to female, which we see, that's in the studies and we see it in practice. So it's rising in girls now. We know that we eat crappier than we've ever eaten. We know that, we put a lot of funky hormones in us, and medicines in us when we're pregnant and when we're delivering. And so who knows? Yeah. I don't know. I think it's very valid that a big reason for it is the rate of diagnosis, but I don't have a complete answer.
Yeah. Yeah.
Nice. Next question. Someone asked, how will the increase in overall behaviors amongst children be addressed as we're seeing huge increases in school? Seems like too much tech mixed with less movement is huge. Add on processed foods.
Your obesity you're talking about.
Yeah. Or how will, this is a question, how will the increase in overall behaviors amongst children be addressed as we're seeing huge increases in schools?
Okay. Well, I'm guessing that what the question's around is obesity, because in terms of behaviors, I agree. Every study I come across, and you don't need a study for this, shows just how poisonous a sedentary lifestyle is. I was listening to actually a podcast last night. It's a physician. He was actually a surgeon, and he was a surgeon. I think he's from UCLA, and then he stopped surgery. He had poor health himself. Then he kind of spent a year researching functional holistic medicine, and now that's what he practices. And his advice to his clients are to do what do you call it? Exercise snacks. So if you're sitting for 45 minutes, never sit for an hour. At the 45-minute mark, if you're at the computer working or if you're in a meeting, you then take a 15-minute kind of walk. Yeah. And any 45 minutes you're sitting, you do these exercise snacks, he called them. And I can tell you that if I'm sitting for a prolonged period of time, I feel like crap when I get up.
Yeah.
Your body's not meant to sit. I always tell people, one of the things I love about what I do is the physicality of it. I like walking from room to room. I like having to get up, lean in and check a kid's ears, turn around and talk to the parents. When I see sometimes one of my friends who's an accountant or a lawyer FaceTimes me in the middle of the day and he's just sitting there like this, I'm like, thank God I don't do that. Thank God I have to get up and walk around and I get my steps in. And so when you go back to the kids, it is nuts. It is nuts to me that they decreased PE class. It's nuts to me that kids can't go outside and play. Believe me, I'm a big fan of academics, trust me, but it's not more important than teaching kids good physical habits, getting outside, exploring, being active. To cut that, to me, along with art classes, sacrificing these things for what? It doesn't make sense to me. And so I think, and you sprinkle the screen time on it. I don't know if you know this guy, Dr. John Haidt. He's a professor from NYU. He wrote a couple of books, and I find his work, especially on screen time, to be incredible. And look, nobody's more guilty of it than me. I'm always on my screen. So I plead hypocrisy 100%, but it is very unhealthy for our kids, right? And we didn't even get into, not that it prevents them from going outside, right? They're just sitting on their screens, but what is coming into their brain from those screens, right? And a lot of it's, very stressful from a mental health standpoint. So I think, there's a simple solution here, that there should be a certain amount of physical activity that takes place every day for our kids, and that'll imbue the right habits on a go forward basis, right? So I think the point's well taken.
Nice. Next question comes from one of our moms. She asked, my kid was just diagnosed with gastroenteritis. When should I be concerned about dehydration or other complications?
These days we're pretty good at it. And if the child goes more than 12 hours without putting out urine, if the child is listless, not, any kid who's sick is not going to be active. They're going to be less active than usual. That's not what I'm talking about. I'm talking about listless, like a wet rag just laying there. But no urine for 12 hours, the kid's listless, but maternal intuition. If the mom thinks things are going in the wrong direction, then you got to message us, and then we could FaceTime. We can check the child and go from there.
Nice. Next question. Someone asked, what are the key distinguishing symptoms between common pediatric viral infections like the flu and viral infections versus bacterial infections such as strep throat? And how does the diagnosis impact your treatment plan?
Okay. So, things like the common cold that are viral, usually the symptoms are, stuffy nose, cough, low grade fever. I think when things escalate to more of a productive cough, or for example, having high fever, or if it's prolonged, those things sometimes could be clues. Now, viruses, sort of the way that we treat them is supportive in nature. So we make sure that the kids are drinking enough, that they're eating enough, that they're getting enough rest. For bacterial infections, and sometimes viruses can have a bacterial superinfection. So on top of the virus, there's a bacteria that takes hold. Those would be treated with antibiotics. Antibiotics don't treat the viruses, but they can treat the bacteria that can be superimposed on them.
Nice. Next question. This one's good. Someone asked, lately my daughter has been complaining that she's sick with something. Could it be possible that it's all in her head? She has a quiz on Wednesday, and she woke up saying that, Mommy, I don't feel so well.
It could be, but I would be careful to just assume that, right? It certainly could be. And if the child has like a track record of, I don't want to say faking it, but if that's not typical for the child, and you check, is there a fever? How does the child look? Is she pale? Is she lethargic? And if you're not sure, that's why guys like us exist, right? You come in and we get her checked out. I would just be careful not to just out of hand assume it's a fake.
Nice. Next question for Dr. Lamacchia. What are the features of the best pediatricians in your opinion?
Caring.
Having taught
caring. I read a great book, Cutting for Stone.
Yes.
And one of the things that the mentor asked the student, what's the number one attribute of a good doctor? And he said caring. And I think that's so true. Communicating well, listening. After you do those things, listen and communicate well, then examining and coming up with what your thoughts are of what the child has, and then acting upon it. But if you don't start with caring and wanting to have that relationship with your patient, I think everything else, even if you can do it, I don't think works as well.
Yeah, I would just say that that response tells you why Dr. Lamacchia is who he is. the funny thing is, it's a lot of like, not just even in this kind of conversation. I've just noticed as I've gone on my journey, I've noticed that sometimes the like simplest stuff, the stuff that's the least complicated, is the rarest. And you say caring is the most important thing, and people would think that that's kind of very, very commonplace. And I think when you consider how that translates as a doctor, right? It's going the extra mile for every child, making going the extra mile the norm. So it's actually not going the extra mile, right? It's no longer going the extra mile. And back to simple advice. I remember when my dad, my dad's not like a pontificator. He's not like a do this kind of guy. He kind of just leads by example, and he'll whisper in your ear once in a while. That's how my dad's style. When I was, when I went to med school, his advice to me was the foundation for everything you're going to be, as a doctor, is going to be based on knowing the basics. It's not the most important part of what you have to do, but you can't be great if you don't know the basics. Mm-hmm. So that was his advice in medical school. When I went to residency, he said, listen, you don't know anything and you're going to be taking care of people as a resident. He said, what's going to make you or break you is your relationship with the nurses. He said, you don't know anything. You're going to be dealing with really sick kids in Newark or wherever. And you're going to miss stuff and screw up stuff because it's the first time you're seeing X. It's the first time you're seeing Y. If you're nice and kind to the nurses, they've been doing it for 20, 30 years. They're going to be up at night when you're sleeping in the call room, and they're going to tell you, go back and look at this kid again. He said, don't be the doctor who's an ass to the nurses. They're going to make or break you. He gave me that advice in residency. And then when I was done with residency and I started to work professionally, he said, all you need to do, he said, it's very simple. He said, just treat every kid the way you would treat your own. Mm-hmm. And he said, if you do that, you'll never go wrong. And it's true, because even if you're not sure of what's going on in a complicated case, but that night you call the family, you check on the kid through the night. The next day I call somebody like you, somebody who knows more than I do. I say, Mike, I got this case, blah, 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 blah. The day after, I'm chasing it. I'm figuring out. The family knows you really care. The kid knows you really care. And by the way, they're getting the best care because you care. You couldn't do more, right? So our job is second to have the answers, but first to really care. Yeah. Because we're not always going to have the answers, but we could always care. Right. And so I think what you said is simple but profound.
Agreed. Next question. Someone asked, have you seen a change in RSV prevalence after the vaccine has been made available and given?
I'll answer that. Unfortunately, there's not widespread availability of the vaccine. And it's too early. This is the first year that it's come out, so it's too early to say. I think when there's more widespread availability of the vaccine, both to pregnant moms and to babies, I think we will see a difference. We saw that already at-risk babies that we give an older version of the monoclonal antibody palivizumab. That's a mouthful.
Synagis, yeah.
Synagis, yeah, that's what I know for.
Which is 5 months during the winter season, and those are for kids that are premature or that have heart disease or that have immune deficiencies. So we've been giving it to those kids. And now, ironically, those kids are the ones that we don't see in the hospital. So now we see everyone else. And still RSV is the number one reason to be admitted in a hospital in the first year of life. So I think that giving the vaccine will certainly make a big impact on that when it's even more widely available, both to the moms and to the babies.
Nice. Question for Dr. Lamacchia. Knowing what you know, can you speak about the testing for Lyme disease, since so many people have some antibodies that are positive, and how do you verify it? I have been to so many infectious disease doctors, and they all have different answers on whether I actually have Lyme disease or not.
Yeah, that can be a tricky one. Okay, so for kids, the majority of kids actually, I think 86%, will actually have the typical bullseye lesion, or have multiple lesions after that that are not as well defined as that first lesion. So I start off by asking, do you come from an area where Lyme disease is prevalent? Okay, so if you're in an urban environment, you probably don't have access to the vector that causes Lyme disease. Secondly, what time of year are we talking about, right? So the ticks that harbor Lyme disease are mostly the ones that you'll see in the summertime when you're more exposed to tall grasses and so forth. Many times, sort of vague symptoms or multiple symptoms get put into a category like Lyme disease. But I think it's important to kind of tease that all out and get a good history and do all of that, and not necessarily run to getting a test. So the test consists of initially something looking at immunoglobulin G and immunoglobulin M for Lyme disease. But then there's a further evaluation doing a Western blot, which is dividing up the various components that make up the bacteria itself of Lyme. And, you need a certain number for IgM to be positive and a certain number for IgG to be positive. So you have to take it in that context. Many times we will actually have certain components positive and not have Lyme disease because some of the components actually cross-react with even bacteria that we have in our mouth. Or you may have had Lyme disease, but it was, a while ago, and that may not be what's happening now. So it's a bit tricky, and it depends.
There's no one blood test that tells you definitively, right. And therefore it can be tricky. And you have to have the constellation of the symptoms with the congruent blood test, right? So it's tricky.
Nice. Next question. Someone asked, curious to hear your thoughts on transient ticks in children. Treatment, or do they mostly go away on their own in time?
I mean, I see this a lot, right, in primary care. They almost always go away, actually, right? They almost always go away, and they almost never go away fast enough for the parents, right? And so it's one of those things where, as the doctor, you're sitting there, and the parents are very distressed, rightfully so. It's very disconcerting when your child keeps, doing this. And you're wondering, Dr. Baker, is there something wrong with his eyes? Whatever. I have an uncle who has Tourette's, and you need to make sure it's nothing serious. You have to make sure there's no focal neurological issue and so on. And you have to be very careful about that. But most of the time there isn't. And it's a stress coping mechanism, right? Think of it as an extension of thumb sucking and or grinding your teeth at night and or cracking your knuckles. It's just a more amplified version. And parents really struggle. I mean, I see this every day. Parents really struggle with the concept that their kids have stress, right? When I sit and I'm telling a family, they come in with a 7-year-old who's doing something that they're convinced is medical. And they're like, Dr. Baker, he's been doing this, go do 85 tests. And after you listen and you take a good history and then you examine the child and you find no real medical or objective or organic issue, and you tell them, listen, this is in his head. They sometimes misconstrue that as fake or as a psychiatric disorder, when it's not necessarily that. It's just the way you or I get a headache after a long day of work. This is his headache, effectively. And so you have to spend a lot of time with the families explaining kind of all this. And then the treatment is very difficult for the family because there's no prescription. And the treatment is to just stop addressing it. Stop telling Jimmy, don't keep ... And every time you do that, you're just adding days and weeks of it. And what's worse than the parents is the grandparents, right? They come home, they're like, no, there's something wrong with him. Tell him to stop, blah, blah, blah. And so it's the good news. It's generally very benign and self-resolving. The bad news, it's only self-resolving. You can't, prescribe anything for it.
Nice. Next question for Dr. Lamacchia. Can you speak a little bit about long COVID in pediatrics? Does it exist? And if so, what should I look out for?
It can exist in pediatrics where there's symptoms of fatigue that remain for a prolonged period of time after having had COVID. Luckily, it doesn't exist as often as it does in adults, so we don't see it so often in kids. Kids usually do better with COVID than adults have, but they also have an entity that doesn't occur in adults, that only occurs in kids, and thankfully very rare, called MIS-C, which is this inflammatory response that kind of looks like Kawasaki disease, but it occurs usually in older kids that need supportive care and sometimes also medications and hospitalization. Luckily, that's not so common an occurrence, and long COVID is less common than it is in adults.
Somebody asked what are long signs of COVID in adults. Maybe we'll save that for like EAD or someone. Next question. Someone asked, and if she can maybe thoroughly explain, if child has low IgG and there's a decline in numbers, what could this lead to? Could the use of steroids and inhaler be a cause for a drop in IgG?
You want to take it, Mike?
So the question is, if there are decreasing numbers of IgG, whether
Could it be due? I'm assuming it's an asthmatic or something.
Yeah. Asthmatic kid.
Yeah, well, the medications for asthma don't decrease the immunoglobulins. Immunoglobulins are related to producing a response to an infection or an inflammation. So the treatment for asthma wouldn't reduce the amount of immunoglobulins, which is the body's way of fighting infections.
Nice. Next question. Someone asked, what do you think is the biggest change in pediatrics disease in the past 5 years?
What are you seeing, Mike? I mean, the last 5 years, it's COVID.
Yeah,
Right?
yeah, and respiratory infections. So because of COVID, and we were masking for that period of time, some of the viruses that cause respiratory infections, we didn't see them because we were effectively not spreading them. But what also has happened is that those same kids didn't develop immunity during that time because they weren't in contact with those viruses. And now that we have not masking, now they're getting some of the respiratory viruses that they would have gotten when they were younger. So that's one of the things that I've been seeing. And you touched upon developmental issues that we see a lot of.
Yeah, and also through the pandemic, now that you're framing it up, what I've seen is skyrocketing anxiety in kids.
Yeah.
Next question. Someone wanted to know, what is the relationship between private practice doctors and hospital doctors?
Depends on the private practice, depends on the hospital. There's a comment. I mean, I want Mike to do most of the answering for this, but from my humble perspective, there's a concept in medicine. It's like a colloquialism about town and gown, as we say, right? And the town and gown is like this kind of, I don't want to say unspoken, but this potential friction that exists between academia and community physicians, and it's understandable, right? I don't want to speak for Mike, but he has many responsibilities. His responsibilities range from supporting academic research, teaching young doctors, how to become doctors, kind of a big deal. Offering a lot of very specialized services to service guys like me and their patients. Also do what we do and provide primary care. Also manage ICUs and deal with some of the sickest kids in the state of New Jersey, whether it was a motor vehicle accident or what have you. He has, 50, 60 jobs that are each very complicated. Like everything I just said for an idiot like me would be a full-time job, right? And Mike has to oversee all that. I really have two jobs as a private pediatrician, right? One, I have to manage my practice. I have to just sustain a practice. And two, I have to try to deliver exceptional care to the kids that I see in primary care only, okay? I think on the academic side, the hospital side, their world is much more complicated, okay? I think our world in some ways can be harder. And what I mean by that is Mike has a million balls to juggle, but in the end, Mike can pick up the phone and say, cardiologist, you need to see this kid from infectious disease down the hall. Whereas if I need someone to see one of my kids, I'm lucky I know people and I can get them in, but most community guys struggle to get them into these specialized services. And so it's harder, right? Because you don't have many moves to make. Mike's world is more complicated. That's really what I've seen. What I think matters the most, though, is everybody having empathy for the other side, because there's some guys and gals that when I pick up the phone and I call and I say, hey, it's me, I think they understand I'm not calling to be difficult. I'm calling, there's a reason. And back to treat the kid the way you would treat your own, right? Like I'm desperate in this case, please help. And somebody like Mike gets that. There's times, I always get, this happens sometimes. I'll get one of my doctors, they come to me, they're like, Z, can you talk to this ER about blah, 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 blah. I'm like, why, what happened? They said, well, I sent this patient over and the family came back the next day and they said the ER doctor said, I don't know why you're here. You don't need to be here. Your doctor, blah, 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 blah. And there's all this friction that's unnecessary and so on. And I always tell that ER doctor, I will pick up the phone and call them. I'll say, my friend, listen, two things. One, if we didn't send anybody over to you, you wouldn't have a job. Let's not forget that. And two, what did you sign up for? Did you think that 100% of the visits that came to your ER were going to be ER qualifying cases? 80% of ER visits are primary care visits that, but if the kid comes in, they have right lower quadrant abdominal pain at 9 p.m. and we don't want to wait till the next day. And there's a 50-50 chance it might be appendicitis. Maybe it's mesenteric adenitis. Maybe it's gastro, but it could be appendicitis. If it's my kid or your son, we would take the picture that night, right? It doesn't mean there isn't a doctor who's going to bat 1,000, right? And that's why you exist. And so we try to forge those relationships. The good news is the majority of folks on all these sides completely understands you're trying to give the best care. And I think some of the stress that exists in the system is really due less to people not having their heart in the right place and more to a lot of the systems and processes. And kind of what we're talking about with the developmental stuff, people would be shocked. And, if they hear two doctors say this, they're like, you guys, whatever, even though we were talking about this earlier, Mike and I, even though we're spending more money and more resources as a country than people can imagine on healthcare, in many ways, that money is not going to the right places. It's not going to multiply the developmental doctors. It's not going to have better virtual care to keep kids out of the ER. And so unfortunately, the system is bloated in the wrong places. And so sometimes that causes frustration for all the parties, right? The specialist says, well, why didn't you go to your primary care? Well, my primary care couldn't see me. The primary care says, I can't get you into the specialist, and kid ends up in the ER unnecessarily or so on. So I think by and large, you have, people who lead with their heart and with empathy. Sometimes you don't. And the most important thing is that any of that cost hopefully is bore by the doctors themselves and the patient's protected from that. Mike, I'm curious if you have any comments on this.
Yeah, I think the relationship between, the hospital and the private pediatricians is very important. One of the things that I tried doing is actually visiting pediatricians to understand what are they going through, what are their needs, what are their struggles, right? And for training, residents that train in hospitals and academic institutions, they are very skewed in what they see, in the way that they practice. So one of the things that we do is partner with pediatricians in the community, private practice pediatricians, for them to see that other side, which I call the real world. And I think you're right. We have a lot of tools at our disposal, and I think it's a really hard job to be a pediatrician in private practice, because you really have to recognize, the things that are, commonplace and routine, but you have to also see when the unique thing comes along that needs, more attention, and also to do things, effectively and efficiently, and give the amount of time that's needed to see patients. So I think it's a hard job, and you're right. We have to understand both sides of it.
Nice. Next question from one of our moms. She asked, why does Hep B still need to be given at birth if the mom tests negative for hepatitis B?
During pregnancy, I presume.
Yeah. Because in my estimation, sometimes we don't know mom status. Babies are sort of a captive audience. They can have come in contact during the pregnancy. So having the vaccine at that time prevents some very bad consequences. When babies get hepatitis B, they have an increased risk of having cirrhosis and cancer. So we oftentimes opt for safety, even though there's many indicators that we might think of being safe. It also depends when mom has gotten tested. So potentially at the time of delivery, her serology may have changed. So vaccinating the baby then or soon after birth is going to be very important, because it can prevent the sequelae. What do you think?
Yeah, there's still several hundred babies a year in the United States that contract Hep B. So we know the system's not perfect, and we know there's a place for the vaccine. It's very rare, and it's rare due to the testing, but it's not zero. And so, who wants to sign up for their kid to have a 1 in 1,000 or 1 in 10,000 chance? It's great that we have good protocols in testing and we minimize it, but until it's zero, it's not. And 1 in 10,000 is 1 in 10,000 till it's your kid or your patient. And if we have a safe and effective way to bring that to closer to zero, then you would opt for that. And so I think, look, I understand the question, and the person, it's IV drug abuse or unprotected sex or whatever, and I'm tested. So I don't think it's a misplaced question. I get it, but in terms of why it's done, that's the answer.
Yeah.
Nice. Next question. Someone asked, do pediatricians still give fluoride supplements, and if so, at what age?
These days, less so, because just in my career, we've seen when we send to the dentist and when we start using fluoride formally, greatly decrease. It started at 3 years, then it went down. Now we send kids to the dentist either 6 months after the first tooth erupts or their first birthday, whichever comes first. So I'm sending 10 and 11-month-olds to the dentist. They do a fluoride varnish there. They then check for malformations and teach the family to start using fluoride. So we don't need to supplement as much.
Nice. Next question. For Dr. Lamacchia, can you talk about any new research you are involved in at St. Joe's?
Respiratory viruses. So we had been involved with things to prevent RSV. So we had been involved with the original Synagis. That was one of the things that we were involved with. And we're doing not only clinical trials, but looking at treatment options and for things like like otitis media and pneumonia. Those are things that we've been working collaboratively with other sites at.
Nice. This one's good. I'm a Patterson native, and I want to thank you, Dr. Lamacchia, for all of you've done serving the children of our community for so long. God bless you. What are some things on a community level that we can do to improve our health?
It's a good question.
Yeah, it is. It's a very good question. I think all the things that you talked about, right? The wellness, diet, improving, activity, those, concentrating on the preventive side is, I think, the number one thing for better health.
Yeah. A lot of the old school stuff, right?
Yeah.
Fresh fruits and vegetables.
Yeah.
Less fast food, more, whole foods.
Yeah.
And then, simple, very simple stuff is your child running around outside 1 hour a day? Very simple. They'll get their vitamin D, they'll get their exercise. Is your child reading 1 hour a day? Right? Expand their mind, learn, explore, positive outlook. Is your child doing some version, and I hesitate to use the word because sometimes people think it's overdone, but some version of mental fitness, call it mindfulness, meditation, yoga, whatever, some mental fitness, some, kind of positive light to their brain, right? And are you avoiding screen time, right? So avoiding negative things, avoiding fast food, avoiding screen time, avoiding a sedentary lifestyle. Sometimes I listen to these conversations about why are there rises in these anxieties in the kids and adults? Why are there rises in obesity? And I say, well, here's why, right? It's actually not a very complicated paradigm. And people say, yeah, but, and then I say, but are we doing these things? If you don't really have many families say, Dr. Baker, we eat great. We really never go to McDonald's. We exercise just an hour a day, 5 days a week. We do yoga a couple times a week as a family, and it turns out it's not working. Right? You don't hear that, right? And so I think people overcomplicate things. We offer vitamin infusions. We offer yoga at Baker Health. We do all these cool things. I will be the first to tell you those are awesome things. I love them, but you don't need to do those things to be healthy. You can do basic things. I think these things amplify and really elevate your health. But if you don't do those things, if you're watching this and you're wherever you are and you do just 20 to 30 minutes of exercise, every other day, if you go for long walks for an hour at the end of your workday or at the beginning before you start your workday, if you do some kind of mental fitness or meditation, there's apps for it. You can just get an app and do it. And then there's other, what I call tier 2 things. Like something I've been learning about a lot is the impact of relationships. The relationships in your life have a profound, I actually think this is going to be the next version of health is there's going to be a focus on how much the people you surround yourself by have an impact on your health.
Yeah.
And I've seen it on a personal level, and I see it in the people I observe where one of my friends might be in the dumps. He's suddenly miserable when he wasn't. He's suddenly depressed. And from the outside, I'm like, it's because of person X, Y. Like it's so obvious, but they can't see it. And I've seen it in myself, right? Unfortunately, not everybody that you're going to come across in your life is going to empower you or is going to be a positive influence. And so, those are health that to me, that's in the category of healthy habits is, whatever the saying is, you're the average of the 5 closest people to you, right? You're going to kind of, be that average yourself. And like, if you're with cynical people, negative people, that's not going to not rub off on you.
Yeah.
And so I think that's going to be the new frontier, but I think just these basic things at a community level are important.
So this one's directly for Dr. Lamacchia. Can you talk about EBV blood test and your thoughts on blood testing for Epstein-Barr virus?
Yeah, I think my thoughts about testing for Epstein-Barr virus is if you have the symptoms of, mononucleosis or EBV. I think, a lot of times people ask for EBV testing because they think it may be related to things like chronic fatigue or not feeling well. I think where the role of EBV testing comes in is if you have, sort of the symptoms that are consistent with EBV, having prolonged fever, having lymphadenopathy or swollen lymph nodes all over your body, on examination, having a spleen that's enlarged, a liver that's enlarged, having liver function tests or assessments of the health of your liver that are elevated. The constellation of these things together, the suspicion of EBV, should prompt an evaluation of it. And sometimes you have EBV, and for any other reason, you get medications like amoxicillin, and it could bring on like a big rash.
Yeah.
And we say, that's the connection.
Yeah.
So I wouldn't routinely evaluate for EBV unless there's disease that's consistent with it.
Yeah.
I think that's it for the medical questions. Someone asked, they wanted to know what's the hardest part of your job and the best part of your job for both of you.
I'll let you go first so I could think.
The hardest part of the job, I think, is meeting expectations, right? People come that you have a relationship with, whether it be a patient or whether it be the educational area, and they come with an expectation. And, the hard part is, to meet that and, to give, what's needed. I think the best part of my job are the patients that I see. I do a lot of administrative work, working at the hospital, and I do research and I do teaching. But the thing that I enjoy the most is like today, I was on service rounding, and I really, really loved it. I really enjoyed it, and I wish I could do it more. And having a relationship, speaking to parents and to kids, and it's very, very enjoyable. And some people are really lucky and do it a lot more than I do.
Yeah, that's a great answer. I think where I sit, the hardest part and the best part is probably the same. It's two sides of the same coin. And I think what I would say is the hardest part is a lot of what we discussed this evening, the non-clinical systems and frictions that exist in healthcare that many times are astounding, right? Like we have these breakthrough medicines, like we're talking about the HIV story, and then we don't have enough doctors to diagnose kids with autism.
Yeah.
That's crazy, right? Like every time I stop and consider that fact, or I consider the fact nutritionists, even mental health providers, Mike, like
time.
When I have I'm not talking about developmental, I'm talking about a therapist.
Yeah.
Right. The 3 therapists in the area don't take insurance and blah, 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 because of scarcity. And so I consider, we're trying to get to Mars now. You turn on the TV, my iPhone does more things than I ever thought it could, but we're short on therapists.
Yeah.
And so it's the systems failures in healthcare that are the worst part of my day. The best part of my day is when we come up at Baker Health with innovative solutions to get breakthroughs. And then when we could systemize those breakthroughs. So what I mean is we said, screw it, we're just going to bring mental health into the office. So I think almost all our offices in New Jersey have a therapist now 1 to 2 days a week seeing our members.
Great.
Yoga. We talk about community-based solutions. We do yoga in all our offices now. We just do it in the offices. And we have a space for it. And then we have yoga studio. Immune issues. People feel run down. They've been sick back-to-back weeks. We give them vitamin infusion. So I think when we're able to have breakthroughs for the frustrating part of the healthcare system and then systemize those breakthroughs for our community at Baker Health, that's the greatest part. It's not easy.
Yeah.
People, I think from the outside, I don't know what they think. I don't know if they think it's easy or it's not. It's very hard. I have Mo sitting here. He's like my brother. He's, day and night, he's there. It's like a battle every day. In many ways, the easiest part of the day is being in the exam room.
Yeah.
To be honest with you, because there's no friction. You have a family. They want what's best for their kid. It turns out you want the same thing, and you trust each other, and it's actually a beautiful thing. I'm sure you feel this. I can't imagine doing anything else.
Yeah.
It's not work when I'm in the exam room. It's hanging out with awesome people who want what's best for their kid, and they trust you to do that.
Yeah. It's a privilege.
that never ceases to amaze me, right? Sometimes I come out of the room, I'm like, God, like, I better not screw this up. Like, they trust me with their kid, right? Like, and I never ever take that for granted. That's great. And then, oh, well, Z, we can't find an imaging center because they don't take this patient's insurance. Like, what? All right, and now do this, now do that. And then we find an imaging center that does, and then we convince them to open 3 around us. And now that we're working with them, right? Oh, we can't get into mental health. We can't get therapy. Okay, blah, blah, blah. Let's do it through the app, or let's do something. Let's solve it ourselves and then systemize it. And so I guess it's 2 sides of that same coin.
Comment from Iyad. He said, Dr. L, you're the man. Thank you for all you do, sir.
Yeah.
I had one more question, medical question. Someone wanted to know your thoughts on weight loss shots in pediatrics and then bariatric surgery in pediatrics.
Okay. So for bariatric surgery, we've actually decreased the ages that we do bariatric surgery. So it's based upon developmental, how that child can then go after the surgery and continue the maintenance. But it's for kids that may have very high body mass index or may have already serious complications of obesity, like, for example, having high blood pressure, having, joint pains, things of that nature, having diabetes. So the combination of both. And this is now a standard not only of the American Academy of Pediatrics, but it's also a standard of the American Academy of Bariatric and Metabolic Surgery. So that's one thing. As far as the new medications to treat the type 2 diabetes that have been used also in weight loss for adults, that's something that is gaining recognition even in pediatric populations. I think there needs to be a lot more knowledge about it and studies about it. But I think that's also going to be a direction that's going to be taken to maybe prevent having to do surgery.
Yeah.
Nice. And to wrap up, Christmas plans.
I'm going. Iyad's having a Christmas. Sarah's having a Christmas party on Monday. You're gonna come?
Yeah.
At their house
I don't tell. Yeah. I'll come.
after their office. So after work, and I'll be in the office Christmas Day.
Dr. Lamacchia.
So Christmas Eve, big celebration.
You're Italian?
I am Italian.
Yeah, they do it big.
So we do a lot of fish.
A lot of fish.
So there's this thing about the 7 fishes. It's not really an Italian thing. It's an Italian-American thing to do 7 fishes. I don't know the number, but we do a lot of different types of fish. I love to cook.
Okay.
My parents had a restaurant when I was growing up, and I was always in a kitchen. So I love to cook. So,
What do you do? Chinese food? No.
So, that's what I'm now planning. I'm, thinking the timing
And you could cook
the cooking.
Anything, or
Just about. I love cooking.
do you cook at most nights? You cook for yourself?
A good portion of them. Yeah. Yeah. I'm the food cook, and my wife does baking.
Oh wow,
She loves to bake.
nice.
Yeah.
She does the cookies, you do the fish.
Right.
Mike doesn't do enough. He decided to pick up cooking.
Yes. I love to cook all different things.
Well, Mike, I can't thank you enough. This was awesome. Can you promise that down the line you'll do this again?
I would love to.
Okay.
I would love
Yeah.
We're gonna have to do this
We
again.
need to do it again for sure.
This was awesome. I can't thank you enough on behalf of everybody who's listening, I'm sure, as well. So thank you, my friend.
Thank you for inviting me.
Yeah.
Thank you so much. Thank you.